We'll go on with the next presentation. Dr. Srinivas and Harshul are remaining. So Dr. Srinivas.
Thank you, madam. Thank you, Chitra, madam. I'll try to finish my talk in 3 or 4 minutes
thanks
maximum.
to me.
3 minutes? Okay.
Yes.
Okay. So this is about the management of the CME post-cataract surgery. So I'll just give you, see this picture. Do we see anything? No. This was actually a patient on diabetes, post-cataract surgery done 2 months, 624 right eye pseudophakia. Okay, so this is the OCT picture which shows IRF, SRF, both the things. Now coming to the next 55-year-old male, treatment on diabetes since 15 years, cataract surgery done, left eye 6/9, quite pseudophakia. See the fundus pictures, again, no much of clinical changes. See the OCT, you see some IRF changes, some cysts here. So this is the another case, diabetes, hypertension. So, hypertension was 160/100. Now you see this edema, right? So now, if you have to differentiate the post-cataract CME, I think definitely you can do it on the OCT as well if things are not very clear on the clinical fundus photo pictures. So there are various things. It can be a vascular cause, Irwin gas, when we usually call it as post-cataract surgery, inflammatory, retinal dystrophies, drug-induced, or even the tractional component. So it can be due to various causes, but see here, the pseudophakic cystoid macular edema is the most common complication post-cataract surgery, all of us know that. But in most of the time, it goes away well. It doesn't go away well, that is when the visual loss keeps happening in those patients. So there are various systemic causes for having post-cataract surgery CME, ocular conditions, the surgery associated like inadvertent iris trauma, posterior capsular rupture, vitreous loss, vitreous traction, etc., etc. Now look at this. This looks pretty much similar, isn't it? If this had a subfoveal fluid, then definitely we would like to have to confuse it as a PCME when the patients present 2 months post-cataract surgery. But this is actually a DME and not a CME. But here it is cleanly CME. So how do we differentiate it? Usually the foveal contour is often preserved in DME, whereas in pseudophakic CME it is altered. And most important is the location of the cyst. It's in DME, most importantly it's in the ONL layer, whereas in pseudophakic it's mainly in the inner retinal layer or inner nuclear layer. And 25% of the patients only have DME, whereas 75 to 100% of the patients usually have subretinal fluid. So this is one of the striking features we need to differentiate it. Look at this. This is a cystoid space in the center, but you see some hyperreflective foci here, hard exudates. So this goes more in favor of DME and not CME. But look at this, there is no hyperreflective foci, no hard exudate. But the confusion comes is when this starts having hyperreflective foci and hard exudates, that is when we have to differentiate between PCME and DME. Okay? So what are the various treatment options available? Quickly, NSAIDs are I think the best because it inhibits cyclooxygenase enzyme, and many papers post-cataract surgery have shown that topical NSAIDs are more effective than topical steroids in preventing PCME. Ophthalmological journey has shown that there is no much difference between Nepafinac and preservative-free Nepafinac. The only thing is the tolerability is slightly better in the preservative-free. Actually, otherwise there is no much of effects on the CME. Pseudophakic cystoid ketorolac alone versus ketorolac and prednisolone, again no statistically significant difference found amongst the two group. So the most important we need to know is the corticosteroid actually acts at the phospholipase A2 level, whereas the cyclogenase act at the NSAIDs act at the cyclooxygenase level, that is COX-1 and COX-2 inhibitors. So chronic macular edema, Irwin gas, what I suggest, I usually practice is just give a simple posterosubtenon injection if it is not responding with NSAIDs. Comparison of subtenon versus topical Nepafinac treatment, PCME, have shown that Nepafinac in fact is slightly more efficacious. That's what few of the studies have shown. But again, there are other studies, if you see low dose triamcinolone acetonide, ranibizumab, then they say if the patient is poor, not very affordable, then you can even go with the IVTA as well. In another paper, very recent 2021, topical NSAIDs, DEX versus peribulbar, have shown that overall success rate is very much. If you see here, 60% of the resolution happened with the topical NSAIDs alone. But in rest 40 patients, the patient who had 7 patients, they went into intravitreal dexamethasone implant. In rest, they went into the posterosubtenon injection. But all of the 100% of the cases, they went well. So there are various things. I'll not go into the detail of it. And the suprachoroidal injections can also be tried. They are pretty much safe now. Lot of anti-VEGFs are available because it also has an anti-inflammatory property. And this is one paper which has shown Pan-American Collaborative Retina Study Group shows that IVT bevacizumab is also well tolerated in refractory pseudophakic CME. In persistent refractory, please make a note of it. And of course, surgery when there is tractional component. In non-tractional component, theoretically it is to remove the inflammatory factors which are actually causing the CME in the vitreous cavity. And this is the study which shows, and I would like to acknowledge our fellow Dr. Rohan Dedia for giving me the cases and helping me in this. Thank you very much for the patience.